Welcome, everyone. Everyone excited to be here on a Saturday morning talking all about neuroendocrine? I mean, it would have just been easier to have clinic with all of you guys, in my office. But anyway, I'm glad you guys are here. Thank you so much for coming, and we appreciate your support and the support for NetRF and all the good stuff they're doing. They've been around for a long time, and they're like one of the first groups to really dedicate all of their energies towards neuroendocrine. So we owe a lot to them. And I love the fact that they actually kind of changed over to NetRF because they were a different name before. And so doing all the research is super, super important. I mean, it may not seem like it applies today, and it may or may not apply today, but it may apply in 3, 5, 7, or 10 years. So a lot of you may be the beneficiaries of these things. So I'm just gonna, it's a long day, okay? So, and feel free. The brilliant thing about these conferences is they're always placed across the hall from the bathroom because we know you people well. So feel free to just pop out and go to the bathroom if you need to, but it is a long day. And so what I'm gonna try to do is I'm gonna try to touch on some of the topics that we won't delve into details on. So you can see there's a lot of talk about interventions and treatments and hey, Carson, and nuclear and imaging and things like that. But there isn't that much about kind of epidemiology and the numbers, which are way on the rise. So I'll touch on some of those things for now. We'll talk a little bit about pathology, and it's a lot to digest. So if you feel like you have any questions, just ask. I'm sure if you have a question, someone else will have the same question. And of course, everyone on the panel is super, super, super nice, and so just feel free to approach them and ask them questions, and they can answer these things for you. Okay? So I'll try to update you a little bit on some of the things that are going on, and hopefully it'll make sense. So the goal of today's presentation, of just my little presentation, are to talk a little bit about the basics. I'm going to touch a little bit about the diagnostics and some of the symptoms as well too, and then I'll talk a little bit about pathology, and then I'll just very, very lightly touch on my philosophy of therapeutics, and then Dr. Lewis and Dr. Suarez, they'll talk more in detail about these things. But I just want to give you kind of an overall general context in which you can put all this information into context, and hopefully you'll hear a little kind of clinical pearls along the way, so you understand like why you're getting some scan or why you're having some kind of treatment and the timing and things like that. Okay, so people ask me all the time, how did I get into this field? So let me just explain a little bit. So here we are in Denver, right, which surprisingly is actually the same latitude as Rome and Barcelona. I always think of Denver as being like really high up somewhere. It's not. So when I first started, I used to live in Nashville, Tennessee. I used to be at the university in Nashville, and my chairman, he said, okay, kid, you can come do this, but I'm sending you away. So I thought, wow, that's bad. I'm being banished before I even start my job. So he sends me to this place called Uppsala, Sweden, okay, which is north of Stockholm, but it's also at the same latitude as Uranium City, Canada. So I thought for sure he did not like me. But he didn't know me well enough to not like me, so I was like, well, something's wrong. But anyway, it turned out to be an amazing place, so clearly he liked me. So he sends me to Uppsala, right? And Sweden, if you've ever been to Sweden, it's actually amazing in the summer. It's terrible in the winter, but it's amazing. It is beautiful. There are blue skies. It's a lot like this, very dry and just gorgeous. And so very historic. Like that church is 1,000 years old and stuff like that. And that castle, so it's really an amazing place. But I went because they actually had one of the, if not the best, neuroendocrine clinic in the whole world. And so I studied with this gentleman here. His name is Dr. Kjell Oberg. He's a professor of endocrine oncology, and he, the 50 papers are written by NetRF. I think he's like part of a whole bunch of them, probably. I wouldn't be surprised. And so we did surgery there. I learned all about PRT. Then this is a decade ago. I can't believe I'm so old, but it was a long time ago, and a lot has changed since then. Like a super lot has changed since then. So it's really exciting. So that's kind of how I got into the business. So just so you understand. Okay, so let's talk a little bit about what neuroendocrine is. So most people don't really understand what it is, right? And like Elise said, the whole Aretha Franklin thing, I'll mention that too. But basically, eating and drinking and breathing are super, super complicated processes, right? And the thing about it is that you don't have to think about it. That's the amazing thing, right? So I always tell people, if you had to think about moving that bagel from your mouth and out the other side, you would all be in the bathroom right now. All of you together at the same time. It's very complicated. But you don't have to think about it because of these teeny, teeny, tiny little cells that work in the background. And they move water, they extract nutrition, and so they do all these magical things that you don't have to think about so that you can function and concentrate on, riding your bike and being with your grandkids and doing all the fun things that are really important in life, right? Supporting NRF. And the way they work is because these tiny cells are everywhere. They're in the lungs, they're in the GI tract, they're in the pancreas, and they all work in the quiet. And the reason they're called neuroendocrine is what I say is neuro because they're smart, and endocrine because they function with hormones. They secrete hormones to do all these things. So they're neuroendocrine. And these are some of the most famous hormones here. You can see like serotonin and insulin and gastrin, these things. But this is like 7 of probably 7,000 different hormones that your body probably releases. And on top of that, there are receptors, and then there are pathways beyond the receptors. So it's such an unbelievably complicated thing that it's essentially hubris to think that we understand any of it really. So whenever a patient comes in, they say, oh, I feel terrible, and their serotonin is normal. Well, that means that there's some hormone X that's going to be tormenting that person. And so I just try to step back and say, look, this is a very complicated thing, and we should just respect however the person feels, because these things can go a little haywire in people, right? And the interesting thing about it is that they all express this thing called somatostatin receptor. And somato means body, and statin means stop, right? So it kind of stops your bodily function, so somatostatin. And the great thing about neuroendocrine is that we've exploited this receptor to the max, right? So a lot of you take this drug, this shot in your bottom called sandostatin or somatuline, right? So you use that as a medication. We now use it for imaging. That was actually the thing that I used to be big on, was the imaging. So if anyone's had a dotatate gallium scan, right, you have been using this receptor. And for any of you who have been in the door in the past year, have gotten this PRRT Lutathera treatment, you're now using it as a radioactive therapeutic. So we have really exploited this receptor. And so we're very fortunate to have this receptor as a means of treatment, because it really, really works. It's really great. So just a little bit of definition, because people don't always understand it. So neuroendocrine is a relatively new term. It actually came up in about 2000-ish. And it's because people used to use the word carcinoid all the time, right? It's caring for carcinoid was the name of the foundation. So the reason we got rid of the word, we're trying to get rid of the word carcinoid, is because carcinoid, everyone puts the word benign in front of it, right? So everyone says, oh, you have carcinoid, that's not really cancer, right? And then you'll walk in and say, well, I've got bone and liver mets, does that count as cancer? Right, that counts as cancer, right? Sure, it may grow slowly, but it still counts, right? And so a lot of people don't understand that. So we changed the word to neuroendocrine. So if you have, that can be pretty much from anywhere. But if you have a neuroendocrine from a tube, this is kind of how to describe it. So if it comes from a breathing tube, if it comes from a digestive tube, then you can have a quote unquote carcinoid. But that's kind of an old term. We like to use gastric neuroendocrine, or small intestinal neuroendocrine, or rectal neuroendocrine, or pancreatic, or that kind of terminology. So if you see this terminology, this is kind of how it works. So think of the umbrella term as being neuroendocrine, and kind of this quote-unquote old carcinoid term is coming from a tube, and any other neuroendocrine coming out, like pancreatic neuroendocrine, being another subset. Okay, does that make sense? Yeah, I just want to make sure everyone understands the terminology, because it can be pretty complicated. And the problem is your doctor will get it mixed up. And so if he or she gets it mixed up, then how are you going to keep it straight? So this is how it works, okay? And the problem with neuroendocrine is it's very, very complicated. Do not underestimate it. A lot of oncologists who are taking care of terrible lung cancers and esophageal cancers and pancreas cancers, I mean, these people are dying within months. It's really terrifying, right? And so they're like, oh, you have neuroendocrine, that's not really cancer, right? I know a lot of you have heard that term, right? You've heard it before. But it's actually super complicated. Look at this. This slide has like 15 different neuroendocrines on there. Each one of these behaves differently, right? And then each one of these has like 3 different branch points which behave differently, and each one of those has 3 different branch points. So by the time you're done, neuroendocrine is like 100 different diseases, and there's a whole wide spectrum of it. And to be frankly honest, there are very few people who can sniff out all the different variations and try to figure out what to do for you. And so that's why it's actually a very complicated disease. In fact, because it's a slow-growing disease, it's actually, the standards are higher, right? Because if I'm supposed to keep you alive for 25 years and I only keep you alive for like 7 years, I haven't done my job, right? But 7 years would be like a triumph if you had cholangiocarcinoma, right? So it's a different thing, and there's a lot of decision-making, and timing is so super critical. And so it's kind of a weird disease because people don't really understand it. I'm sure a lot of you have had neuroendocrine since you were a child. Maybe you were a teenager when you started having your symptoms, and no one ever knew and never realized. And so what can happen is you can have this, you can have a tumor present for years and years and years. No one knows. No one knows. And then all of a sudden you get some vague abdominal pain, and all of a sudden you figure out, oh my gosh, you have this tumor, but by then it's metastasized, you may have really bad symptoms, and then, let's be honest, people still die of neuroendocrine, right? We see this before. So it's a complicated disease because it's such a long period of time. And here you can see here, the complications from neuroendocrine are very, very real, and we deal with this every single day, right? So hormone excess is super important, right? We talk about the symptoms, we talk about flushing and diarrhea, but it's more than that, right? Does anyone know what the number one complaint of a neuroendocrine patient is? It's not flushing and diarrhea. Devin, it's fatigue. How many of you have fatigue as your major problem, right? Yeah, so yeah, Joe has it because he's on the road all the time. That's right, that's the difference. But it's true. So fatigue is the number one problem. And so she comes to my clinic. How many times do I ask, most of you come to the clinic, and I ask you, like, how do you sleep, right? How are you eating? Are you waking up 15 times in the middle of the night to go poop or pee or something like that, right? And so those are all very, very important aspects. In fact, one of my patients is a sleep expert, so I'm like asking her all the time. So when you do sleep tests, what's keeping these people up? And it's because they can't breathe, right? So they have like these CPAP problems, and so it's a huge issue, fatigue. But hormone excess can certainly contribute to that. And again, it might be hormone X, right? Someday it'll be hormone Lewis, which is causing fatigue, right? He works hard. But hormone excess, is a huge problem. But we think about it not just as symptoms, but, it can burn out your heart, right? So we talk about the heart valve, so that can be a complication. Obviously, there are a ton of mechanical complications, right? A lot of you have had abdominal pain, off and on for the past 25 years, right? And that certainly could be some neuroendocrine hiding inside there. And I'll show you some pictures so you can understand why. Nutrition is a big deal, right? A lot of you have had half of your bowels cut out, right? And so absorbing nutrition can be very complicated. And some people will die of malnutrition, unfortunately. You can have cardiac issues, like I mentioned, and of course, good old anesthesia. Everyone thinks anesthesia is so safe now. People can have cosmetic plastic surgery and anesthesia is okay, but not for a neuroendocrine patient, right? Most of the time, luckily, we get away with it. Everyone does really great. But every now and then you will have a patient. I'll give you an example. The other day I did a neuroendocrine patient, and her blood pressure dropped to 40/0. It was terrible. And I do this every day, and I was really scared. And the anesthesiologist is like, don't worry, I'll fix it. Just keep operating. Stop looking at the screen. And it's true because, I only work with 9 anesthesiologists in my practice. And so those 9 people know exactly what to do every time. Even when I'm freaking out, they're like, don't worry, we'll take care of this. We've done this before. And so having a multidisciplinary team that includes all these people is very, very important. And you'll hear about it as people are talking today. So this is what neuroendocrine is like now, right? Oh my gosh. It's bad when I laugh at my own jokes and I choke on it. Excuse me. So this is what neuroendocrine is like now, right? Do you remember when Baskin-Robbins was only 31 flavors? Right? 31 flavors is much more manageable than neuroendocrine. And so this is kind of what it's like. So in Baskin-Robbins, like 70 different flavors. And you should stop by one here in Colorado because there's a cannabis-flavored one. And you should definitely try it. Definitely try it. Okay, so we all know that Aretha died from it, but there's more than one famous person who's died of neuroendocrine, right? So this is who? Right. Wendy's a fame, right? And so Dave Thomas died of what? He did not. He died of heart disease because this dude loved his work. And when it came to a double cheeseburger, he loved his double cheeseburger. Believe me, I hear these stories secondhand, but they're true. So he's actually an oncologic victory, right? Because he died with the disease than of the disease, right? So that's actually really terrific. And this is right. So Audrey's a little bit different. Hers is a little bit mixed, but she had a lot of abdominal pain for a long time and a lot of digestive and diarrhea issues for a long time, and no one knew because she was so skinny, right? You could never tell, right? And before, the most famous person to die of neuroendocrine used to be Steve Jobs, right? Because he had his neuroendocrine and he did all those kind of funky, goofy things and, whatever it was that he tried. And I haven't read his book, but I was told that in his book it says the one thing you should do is listen to your doctor and work with your doctor and stuff like that. And he had an amazing doctor, so I know he was well cared for. But now the most famous person is actually Aretha Franklin, right? So Aretha Franklin died of it, and this is when she first came out. Look, what is that? right? So that just kind of epitomizes what it is that we're dealing with here, and what, all the different, and NetRF is one of several foundations that's just trying to get out there and work hard to spread the word so people understand what this disease is, because this is a growing problem, right? Okay, so let's talk a little about the numbers, and the numbers are a little bit alarming, a little bit. So the incidence of neuroendocrine tumors, which is the number of new cases per year, has actually gone up a lot in the past 30 years, right? So it's almost septupled, or whatever times 7 is. So it's about 7 per 100,000 people. Now that still qualifies as a relatively unusual and rare cancer. I got that. This is not breast cancer. This is not colon cancer. This is not lung cancer. I understand that. But you know what? At the same time, there are a lot of people walking around with it, right? So what does that mean? So just take a look here. So if you look at the incidence of all cancers, right, that's the blue line up top, it's relatively stable over the past 40 years, right? But if you look at neuroendocrine, and a lot of it admittedly has to do with classification and coding and names, like I told you, but the numbers keep going up. And you can see here it's been creeping up for the past 40 years. And it's real. I think a lot of people feel this and see it kind of anecdotally, even in their practice. I mean, obviously, there wouldn't be so many foundations and companies and doctors who were interested in it if there wasn't a need for it, right? And even if you look within the realm of neuroendocrine, okay, it's still going up, right? So neuroendocrine has, like I told you, has a bunch of different flavors. But look at the 3 that are really going up: lung, small intestine, and rectum, right? So the lung, the imaging of the lung hasn't changed in the past, 30 years. Chest x-rays are the same. CTs are the same since I was a student, right? Small intestine right now is equally poorly imaged now as it was 30 years ago. And the rectum, actually, the rectum I understand because we do a lot of colonoscopy. We pick these things up. So that I kind of understand. But those 2 are going way up. But at the same time, those are also the 2 largest internal organs that are exposed to the universe, right? So it's conspiracy theory, but, it's interesting. It's interesting. Now, the other thing, too, is that the prevalence, which means the number of people walking around with neuroendocrine, is going up, too, right? So these are some more common cancers. This is like liver cancer. There aren't that many people walking around with liver cancer. You know why? They die. They die. They die, okay? Esophageal cancer, same way. Every time I see an esophagus cancer, I just kind of like hold my tongue and hope I don't have to do surgery, because like the outcome is usually pretty rough, okay? Pancreas cancer, right? That's a rough one. That's a scary one. My grandma had pancreas cancer, and it was not pretty when she died. And Dr. Lewis and Dr. Suarez take care of a lot of these people, and it's terrible, right? Stomach cancer, and then here's neuroendocrine. Look, there are a lot of people walking around with neuroendocrine, which is great, right? And about 15 years ago, there were about 112,000 people or so walking around neuroendocrine, but it turns out that number has actually jumped up in 2014 by 50%, right? Again, it's 170, which is probably an undercount, to be frankly honest. So it's probably even more than that. So there are a lot of people walking around with neuroendocrine. And great, if they can walk around neuroendocrine, be healthy and strong and live their life, fine, right? Like I told you, you die of your cheeseburgers and your heart disease, you've won. You've done your job. Or I've done my job, I guess. I've done my job, right? But there are a lot of people walking around with this. So you're not alone. You're not alone. And the question really is, how many people are walking around and don't know? Right? That's really the thing. And they all behave differently. So if it comes from the rectum, you can see most of them are relatively quote-unquote benign. Maybe they don't know they're metastatic yet. But the ones that are metastatic are pretty gnarly. You can see here, that's the red one here. And then look at the ones in the lung. Half of the people walk in the door metastatic, means it's spread from away from that original lung site. And look at the small bowel. I know a bunch of you have small bowel. Look at you. 2/3 of you walk in the door with spread disease. And this is an old slide, which means that probably 90% of you have some kind of spread disease. And with this new gallium scan that we're doing, we're finding more stuff. So in fact, these data are probably a gross underestimate of what's actually going on. But it's okay. We can still take care of you. But it just goes to show you that the disease is very different from person to person, because the zebra is the mascot of neuroendocrine, right? And so I always say it's true, like no 2 stripes are the same. It's absolutely true. And despite the fact that it'll be like, you guys have been in my clinic, right? There are like 15 people with neuroendocrine walking through the door, but the one that walks in is very different from the one that walks out, right? And so that's a fact. So let's talk a little bit about diagnostics. Dr. Gerhold will tell you about kind of the fancy imaging, but I want to tell you just a little bit about how it presents, right? So these are essentially the kind of the medical tools that we have to take care of you, right? I have an office visit. I can listen to you. I can hear what you have to say, which is probably the most important thing, right? I can do some labs, I can do some scans and imaging. We can now do this nuclear imaging, which is very, very powerful. We can put scopes into you, and of course, ultimately, we can biopsy you and figure out exactly what disease you have. So that's essentially the tools I have to figure out what's going on and what's happening in your body, right? And so when you have the office visit, it's important. I sit, for those of you who come, I'll sit with you for an hour. I will listen to you talk about your symptoms since you were 17 years old. But that's important, right? Because if you've had symptoms since you were 17 years old, that kind of gives me a sense of how long you've had them for, right? But look at all these different things: diarrhea, jaundice, rashes, gallstones, abdominal pain. How many of you have these symptoms now, right? Look, anger, right? A lot of you have anger. I think my wife might have neuroendocrine like 50% of the day. But her neuroendocrine is only aimed at me, so I think it's a specific symptom. How many, right? How many of you, the women have walked in the door and gone to their gynecologist and said, I flush? And your first diagnosis is menopause, right? And of course, and how many of you walked in the door and said that you had diarrhea and you're diagnosed with irritable bowel syndrome, right? Of course. So you can see it's a tough diagnosis to make. So, and I gotta say, I'm a little bit lucky. I've only made one diagnosis of neuroendocrine in my whole career. I've only made one diagnosis. And it's only because I looked at the scan and I could see the pattern, I could figure it out. But imagine being a PCP and someone walks in the door and says, I have like stomach pain, right? Well, you're gonna get your Protonix, your Pepcid or whatever it is, and you're gonna go about your way. And then that's how it is, right? And so I don't admire it. It's hard. I'll tell you a story later. Now, the interesting thing is that 70% of patients actually have no symptoms. It's fascinating. Like, they may have very, very vague symptoms. They may have occasional symptoms, but a lot of them are diagnosed on a random CT scan for a kidney stone. Right? So you never know. So whenever I talk to kind of the physicians, or especially the young ones, I would say, look, I got it. The more common thing is like they have gout, or they have a stomach flu, or they have some infection, right? Always think about the horses, right, not the zebras. But the problem is, and so here, right, menopause, irritable bowel syndrome, asthma, sure, think about all those things first. But if you don't at least put neuroendocrine kind of on the differential, that list of possibilities, you'll never figure it out. So I always try to encourage them to always think about it, right? So that's really important. That's kind of how it works when you're starting off. Now, imaging is actually super, super important. So let me just illustrate the imaging in this graphic here. Can you hear it?
Don't tell me it's lung cancer, right?
Well, not yet, thank goodness.
Watch what she does. She puts that thing out right away, right? I love this video. And it's sad, they're both gone now. It's unbelievable. I was a little young when this movie came out. I was really young when this movie came out. But I love this because, this is like Kryptonian imaging, right? It's immediate, and I did not know that Superman was a radiologist. I didn't know. Now, the only problem is that she lives in New York City, which means that her lungs are not pink. Let me tell you, they are black. So I'm not sure about the accuracy and sensitivity. But this is how imaging should be, like just quick answers and get a sense of what's going on. So I'm not going to go into great detail about the nuclear part, but I want to touch base on some of the other ones because all of you have walked in the door with probably like 25 different CT scans and MRIs and things. So I want you to understand a little bit about it. So we can image CT, MR, ultrasound, the old Octria scan, which is still useful in certain ways. And of course now our gallium dotatate, right? And pretty much all of you are familiar with this. But the CT still is the workhorse of our imaging technology, right? So, and someone will walk in, this is a patient I did, she came in because she had like some like very unusual back pain, and so they thought it was like a kidney stone. Made sense. And they found this mass in her pancreas. I know it's hard to tell, it's shades of gray, but that's this thing here. And then here's another fellow who had an abdominal obstruction. Look how beautiful the images are. You can see this is a beautiful blood vessel, and there's a tumor right here in the middle, right? You don't actually have to be a super radiologist to find these things. You just have to be aware that they're there. So there's and the reason I point this out is because it's kind of a myth, right? People say, oh, neuroendocrine is so hard to find, so difficult to find. When in fact, that's not true. Most of the time, you can find a hint of it someplace, and then you can go down the path of figuring the rest of it out. But usually, you can figure it out with just a good CT scan. That's really what it's the chest, abdomen, the pelvis. Just take a look at your torso, right? And so that's an example here. So you can see how this is still, and CTs are unbelievable. They are beautiful, they are fast, and assuming you're not allergic to contrast, you can take quite beautiful pictures of it. And this is super important for surgery, and we'll talk about it in a second. Now, a little pearl for you is that the reason I throw a lot of you guys in my MRI machine is not because the colors are pretty and you can listen to music, but because the MRI actually shows you more detail. Let me just tell you a story. So this is a patient of mine. His name is Fuzzy. He's from Alabama, except he has no hair. He's bald. The irony of it. Anyway, so he saw his oncologist down in Birmingham, and they got a CT scan, and it was read as completely negative. He had small bowel neuroendocrine, completely negative. And his oncologist was a little concerned because his chromogranin was creeping up. So instead of getting a CT scan, he got an MRI. And the MRI showed this. I know it's a little hard to see, but you see this tumor right here? These two scans are the same. And you can see nothing here, nothing at all. So I went, I took it, I took his tumor out, and it took about 45 seconds to remove. And he did great. He left after 2 days. So you can see the MRI is a much more sensitive test, and it can pick up to 20% more lesions. And the CT scan is a little bit rough because it depends on the timing of the injection. So if the timing is off, you'll miss the tumors. So just be aware of that. So the MRI is a little bit more reliable. That's why I use it for the liver. Okay. Now, nuclear imaging, Dr. Gerhol will tell you all about it shortly, but let me just talk a little bit about it. So you see, so this is the old Octria scan. You guys probably remember this. For those of you who had to go in one day and then go in the next day and then go in the day after that, right? So this is how an Octria scan works. It was actually amazing technology for 1990. It really was, because in the past, they would take a Geiger counter and hold it over your body and just try to figure out like the counts based on, I have pictures of it, it's true, yeah. And then when they got this, they thought, oh, this is the end-all be-all. And Dr. Krenning, who's a very famous guy who kind of pioneered and invented this, he resisted gallium for many, many years because he was holding on to this. And even he has converted now to gallium. So just be aware that even the master himself has converted over. But it's still very useful in certain circumstances, especially if you don't have access to a gallium generator. That's the problem, right? We talked about that. FDG, a lot of this is kind of a workhorse for regular kind of cancers that we take care of. It's still very useful in certain circumstances. It's not always, we don't always want to see it be positive because it tends to be more aggressive, so it makes us a little nervous. And then these are the fancy kind of neuroendocrine ones we had. And of course, gallium dotatate is now our workhorse for PET scans, and it has changed the way that I practice neuroendocrine medicine. So here's your Octria scan, just to give you a sense of it. Dr. Gerhol will talk more about it, but you can see here it's a little bit fuzzy, right? And you have to do several scans in order to figure things out. This is like the perfect scan, right? But most of the scans don't look like this. It's hard to interpret. This is the new molecule now. This is gallium dotatate, okay? So like I told you, remember the somatostatin receptor we've exploited and utilized to the max. So what you have here is you have a guided missile, okay? This is the hormone. This is the cage. And this is the light bulb inside, gallium, right? So now I can take pictures of your receptors, which usually correlate with your tumor, okay? Does that make sense? And so that makes a big deal, because if you look at this, so this is a patient of mine from many years ago, and he was from Philadelphia. He was a teacher, and he had two operations. And he went to a very renowned neuroendocrine center down south. And so, these people knew what they were doing. So he gets his Octria scan, and then the nuclear doc says, you left cancer inside there. The surgeon says, absolutely not. That's inflammation that I left inside, just from my operation. So he comes to see me, right? And I had just gotten started, so I'm just this kid. And I say, look, what do you want me to do? These old docs have been taking care of you for a while. What do you want me to do about it? He says, look, I don't know. They can't figure it out. Can you just tell me what to do? So I said, okay, well, look, you're lucky I have this new generator, this new toy. Why don't you try this out? So I stick him in the generator. I stick him in the gallium PET scanner. Yeah, shove him in the generator. No, I'm sorry. So I put him in the trial for imaging, and he actually has this, right? And so you don't have to be a radiologist to figure this out, right? Clearly, we were not dealing with this anymore. And if you look very carefully, you can see like maybe shadows of something. But the radiologist, this is what they're dealing with. So when gallium dotatate came, and I remember the very moment this happened, his name is Dennis, he was sitting with his wife, and I could see that picture as a thumbnail in the corner of the screen, because I turned the screen to them so they could look at it together, and I was like, so I stopped for about 6 seconds just to think about what I was going to tell them, because this was not what they were expecting. So we sent him off. He went to Europe and he got his PRT. So yeah, he got his PRT. But it just goes to show you how it changed everything. So let's talk about pathology real quick. And I'm running out of time, so forgive me. I tell too many stories. The pathology is actually very, very important, okay? Because what information you get out of it will tell you exactly kind of how your disease works. So it comes as what I call the good, the bad, and the ugly. Grade 1, grade 2, grade 3. So well differentiated and poorly differentiated. This is changing, okay? So don't like stick all your, don't take too many pictures of this slide because this is changing. But basically think of it as the good, the bad, and the ugly. And basically we use things like the Ki-67, which is a stain, the mitotic rate, and these things help give us a diagnosis, a sense of what's going on, because it'll give you a prognosis. Is it going to be good, is it going to be bad, or is it going to be ugly? And this does happen with neuroendocrine. So basically think of the grade as how far the gas pedal is pushed down, okay? So if the gas pedal is pushed down, it means all your tumors are growing fast, okay? So just be careful of that. So grade 3 is the worst, grade 1 is the slowest, okay? And then people ask about staging. Well, staging is different, okay? Staging is how far has it blown away, right? So when you blow your dandelions, those little seeds go, how far do they travel? So if it's stage 1, it's just right at that original site. When it's stage 2, it's a little bit bigger, but still contained in that site. Stage 3 means it's leaked a little bit to the lymph nodes, but the lymph nodes have done their job and they've caught it. And stage 4 means it's spread elsewhere, bones and liver. And so that is a very, unfortunately, common thing for neuroendocrine patients do. They walk in stage 4. So I say, look, you're stage 4. Don't worry about it. We'll take care of it. Okay, that's how it is. Right? So the therapies we'll go into in a second, but I want to talk a little bit about philosophy. So the good thing about neuroendocrine, despite it being a relatively rare disease, is that you have a bunch of tools in your toolbox, a bunch, okay? So you have surgery, you have hormone suppression, you have hormone blockade. That's a new therapy we have now. We have these molecularly targeted therapies. We still have some good old chemo in certain ways. You can do embolization. Dr. Nutting will talk about that. And of course the PRRT. So there's a lot of hope because you've got a lot of tools. But that makes it actually more complicated because someone's got to figure out when and what to give you, right? So I think of that very differently. You have tumor control, right, which the oncologists are superb at. You have symptom control, which, like everyone kind of works on, gastroenterologists and everyone. You have hormone control, which is endocrine. Okay, that's what Dr. Fishbein will talk about that a little bit. And so you put them all together. Then and only then can you get actual disease control. But the problem is it takes this long to do all these things. So we will sit here for a little bit and watch this turtle walk across uncomfortably. So you can appreciate how I feel like in clinic every day with you people. No, I'm kidding. But that's really what it is, comprehensive disease control. And that's the whole goal, right? The whole goal is for you to live with the cancer and feel better, right? Feel better, okay. So I'll try to move along. But the first therapy, you should all know, is to what? That's right, good people. The second therapy should be what? Yeah, good. You've heard my talk before. And the third therapy should always be? Oh, Mark Lewis shakes his head. You cut that stuff out because it causes a lot of problems. It's very mechanical. I'll talk about it in a few minutes. But look at it. There are so many tools in the toolbox, and there's a lot of stuff. I'll bet there are days when you leave that clinic and you feel like this, right? This doctor's like, oh, you can do this, and you can do this, and you can do this, and you can do this. And you know what? It's true, right? And it's great. I don't want you to feel like you're out of options. But this is how you feel sometimes, and this is how we feel sometimes. And so it is a very complicated thing. And so I always want to encourage you to see people here on the panel because they're experts and see this all the time. Because if you see find a general oncologist or a general doc at home who just is willing to work as a team, because it really takes a whole team to take care of you, okay? I need to move along, so forgive me. So how do you decide on a therapy? Always think about the risk, always think about the benefit, and think about what are your goals. Are you trying to improve your symptoms because you can't leave the house, right, because you're pooping 50 times a day? Are you trying to get rid of all your tumors? That's a great, great goal. Are you trying to shrink your tumors? Maybe there are therapies that they can give that can do these things. Or are you trying to prevent complications? Because complications kill you, right? So those are the things that you have to watch out for. Or are you just trying to stabilize your disease so that every day you can live healthy and well is another day you can live healthy and well, okay? So here's the key. The art of neuroendocrine is not what to do, it's when to do it. No, this is not funny? No? The fact is true. Right, thank you, Dr. Lewis. Gosh, I hope that was blocked out from the... Anyway, I'm kidding. So here's the NCCN guideline, just so you understand what's going on. This is, and I'm glad, Dr. Kulke and those super famous academic doctors wrote this thing, because I can't follow it. It's very, very, very complicated, right? Because that's how neuroendocrine is. It's not a path. It's not a pathway. It is a web of therapies, and you just have to pull that tool out of your toolbox when the time comes. But they're really good. Look, they updated it with Lutathera, they updated it with gallium, so they're really good about it, which is great. But to be honest with you, this is actually a document for the insurance companies, so they know what to pay for, okay? Because look at it. If I said, here's Mr. Jones, here's Mr. Miller sitting in front of me, right? Do I do this, or 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 this? It doesn't tell you which to do for Mr. Miller. It just tells me what to do to get paid for, right? So it's true. Every individual is different. I really believe in the zebra thing. I think it's super cute. And you know what? We lead you to water, and hopefully you guys can benefit from it, and that's the important thing, and that's why you are here at this conference today. And so just so you know, in addition to NetRF, I also represent a organization called the Healing Net Foundation, a little bit different. Their goal is to improve education and awareness, and especially in the community. So if you're interested in some information, by all means, take a look. But I do want you to watch this video. I know Elise wants me to get off, but you got to watch this video. This is super important. This is why we do this.
Welcome back, everybody.
Turn up the volume.
Earlier, we introduced you to two moms who are raising awareness about water safety after losing their children to drowning.
Now another mom is on a mission. She's turning her grief into something good. Megan shares this story and shows us how this mom is keeping a promise to her daughter, helping others one step at a time.
We took Anna to national parks when she was little, and we always believed in giving her experiences rather than things.
Gil Schenzel shared a love of the great outdoors with her only daughter, Anna Rose.
She grew up in the parks and out in the mountains. She loved adventure, and she loved running, and she was a great kid.
In 2016, when Anna was in college, she began experiencing numbness in her legs and unexplained heart problems. Body scans and MRIs could not detect the cause of her mysterious illness. Finally, a blood test revealed alarming results.
So we went to this endocrinologist, and she said, "I'm really sorry, but Anna has stage 4 cancer."
Those words shattered Gil's world. Anna was diagnosed with a rare, aggressive type of cancer, neuroendocrine tumors, also referred to as NET cancer. The cancer started in her adrenal glands, then spread to her lungs, spleen, and other organs. 20-year-old Anna endured several surgeries to remove tumors and grueling chemotherapy.
She was having a really bad day with chemo, and I just snuggled up beside her and I said, "Honey, I got this crazy idea. Let's go to all the national parks." And she said, "I'm going to run them all with you, Mom." And she was so sick. And then we got told it wasn't working after she'd gone through all of that. And it was really hard.
Anna died last year at the age of 21. Through her deep emotional pain, Gil is keeping her promise to run in 50 national parks, raising money for research and awareness about the disease that took her daughter's life. She calls this cancer a horse of a different color, so she runs as a zebra warrior. Gil brings Anna's teddy bear to keep her spirit close.
I want to do this whole trail someday.
At Cuyahoga National Park in Ohio, Gil was joined by others. Some are NET cancer patients who met through the support group and foundation, the Healing Net.
Cancer teaches us a lot about ourselves, doesn't it?
Yep, sure does.
I just want so much to let people know about this cancer. I just ask God every day to take my brokenness and use it to help somebody else. And if we can help save some lives, then I'm really good with that.
You are an incredible woman. Gil is 2 parks away from reaching her goal of running 50 national parks, and she's running another one tomorrow before her big finale Saturday at Rocky Mountain National Park. It's the same place her husband used to bring their daughter, Anna, while she was a little girl.
There's nothing like a mama's love. Nothing like it.
These mothers are incredible.
Yeah. We'll be right back.
So now you know why we work so hard. And Gil is here. She ran all 50 national parks. She's an amazing lady. She's an amazing lady, and she's been supportive of our neuroendocrine community in many, many different ways. Half of it's just bringing me food so I don't starve. So anyway, so enjoy the day today. It's a lot to talk about, and so remember, if you have any questions, just ask, because everyone here just wants you to understand what's going on. Okay, great. Thank you. Sorry.